very much. Yeah, it's a pleasure to be in Toronto, where, as was noted, I did all my training. So this session is going to be like a very kind of like topical or summary version of the course that we teach at Johns Hopkins, which is say 2 courses, 2 8-week sessions, and then we also now have a DRPH and implementation science. So it's just a really kind of like top-level summary of that, and I'm happy to entertain questions and just have a discussion further. I didn't realize that there would be this great HIV session right before this, and some of you may have attended, so maybe I'll just skip through my little pandemic piece. But I'll say that there really is a role for implementation research and thinking about how we better implement PrEP and ART and really take them to scale in all settings, obviously including in Canada. I'll talk a little bit about the types of evidence that we look for within implementation research, and then I'll talk a little bit about how we measure implementation outcomes, and then just a very top-level summary of like some of the experimental designs that we're using, including explanatory, pragmatic, and increasingly the concept of adaptive designs, which some of you may be familiar with. So yeah, I mean, I think as a pandemic overview, I think there's obviously a tremendous amount of progress. We now have a total of 22 million people living with HIV that are on treatment, of whom about 17.5 million are estimated to be virally suppressed. But it's also, I think it's really important to say that even though we've scaled up treatment in some countries over the 90-90-90 or 90-81-73 guidelines, there actually were 1.8 million new infections last year, and so there's a real disconnect that's, I think, emerging between treatment, achieving the treatment targets, and still actually decreasing the numbers of new infections. And I think it's really the space here between how to scale up treatment effectively to all folks living with HIV, and also then how to do effective prevention to really reduce the 1.8 million new infections. And I'll also say that I think many folks, although the room was full, it was really impressive. In a lot of other spaces, including at Johns Hopkins, it's rare to actually get somebody coming in that's focused or interested in HIV anymore. And I think it's because they've been repeated these messages that it's over and that you can't really build a career in it. And so I think that that's a concern because I think many of us recognize that it's obviously not the case. And we know that there was a peaking of incidence of new infections, and as I noted, it was about 1.8 million in the last year. It's also important to note that about 1 million people died last year. So the idea of the 36.9 million people living with HIV is often treated like a static number, but it's not a static number, right? That if we do everything the same, next year there'll be 37.6 million people living with HIV, and the following year there'll be 38.5, 39, 40, etc. So actually the global treatment needs in this era are only going to increase if the sort of declines in both incidence and mortality continue. So I put that out there as like we often think of these as very static numbers, and when we look at HIV funding for the pandemic response, we also think of them in a very static way, but it's not static, it's actually increasing every day. And that is mostly focused on lower income settings. I'll also say, as was so nicely said earlier, this is a review that's just coming out now, or I should say in the last month, and it basically is looking at the proportion of infections in high-income countries among younger gay men. And what it is basically saying is that while overall infections are decreasing, actually the proportion among young guys is increasing. So in the idea of like achieving an AIDS-free generation, including in Canadian data, there's obviously a fundamental disconnect there. The majority of new infections are being acquired by young guys. So in that space, right, there's obviously, we know what is efficacious for HIV. That message is said a lot. There is PrEP and there is treatment. But clearly there's a challenge there in terms of implementation. And so this is work that was actually reviewed done by David Peters, who many of you may know, another Canadian at Hopkins, but far advanced, the chair of international health at Hopkins. So they did a really nice review where they summarized what is implementation. And what it is that the use of strategies to introduce or change evidence-based interventions. And the important piece here is that it's not just programs. I think often we focus on programs. But you can do implementation science in the context of policy change. You can also do it in the context of individual practices and really looking at implementation approaches. HIV often tends to redefine things, and so with partners at UCSF, we did a review of what were all the different definitions being used for implementation science in HIV, because again, there's sort of this idea that often we redefine what's already out there. And so we found 62 active definitions that were being used. And so we didn't try to create a new one, but they used a really nice approach of a heat map approach to sort of synthesize or create a synthetic definition. And basically that emerged from the 5 key themes that were consistent across all those definitions. And that is basically that implementation science is intended to be multidisciplinary. It's intended to be generalizable, or develop generalizable data, as I'll talk about. It's intended to engage multiple stakeholders in this process. It's intended to close the gap between evidence and practice, and it's intended to be done in real-world context. So I'll just note that 3 of those things are really this idea about real world, like generalizability, closing the gap between evidence and practice, and the idea that you would actually implement these studies in real-world context. How does it fit in within other study designs? Well, there's a lot of overlap between what implementation science intends to do and enhanced monitoring evaluation, quality improvement studies or operations research. And really also within, when you think of translational research, there's also a lot of overlap between T3 and T4. And probably the fundamental difference between what implementation science is intended to do as compared to, let's say, a program evaluation or operations research is this idea of this developing generalizable knowledge. Right? That if you're doing operations research or program evaluation, your fundamental goal is about evaluating that program. And the idea of generating anything generalizable or useful to others is a secondary goal. And within implementation research, the idea is using these standardized frameworks and indicators to create some comparability and some generalizable knowledge. Another key thing is that often implementation research is being done in the context and partners with real-world programs. And while it may be different in the Canadian context, in the US context, there's a real pressure to be successful for the programs. It's very hard to go back to Congress and say, thanks for the $200 million, but it didn't work, right? The program didn't have the outcome that we wanted to, and so it's really important that when we think about really meaningfully integrating implementation research, we do that in a way to make sure that it's transparent. We make sure that we're not afraid of failure, that programs can be implemented but not achieve the outcomes of interest. And it's important to say that, and it's also important to sort of think about asking the question, what is sufficient evidence for you to stand at a podium or you to stand in front of a Ministry of Health and advocate for a particular program? How much evidence do you really need in order to do that? And making sure that you've achieved that level of evidence before you start advocating that something is or is not effective. I think a key difference that's different about IR than others is that often studies are designed by methodologists. So folks like myself with MDs or PhDs or DRPHs that sit in a room and think about study questions and then they try to sell those to a series of funders and stakeholders. I think what should be different and what is often different about implementation research is just this idea of integrating lots of different competencies in your research team as you're developing these questions. So that means engaging government either in whatever setting in which you're working, engaging health professionals or frontline professionals, public health professionals. Often privacy experts are really important here because you're talking about using routinely collected data to which you may or may not be able to use in the way that you want to use it. And also it's important to have communications folks because a lot of the work that you're talking about doing is very real world. And so it's really important to be able to communicate that in an effective way. And also obviously to engage community and really try to facilitate community's involvement in not just end line and who you're reporting to, but really in terms of generating questions. There's really lots of established conceptual frameworks. There was a recent review that came out this year about conceptual frameworks used within implementation research, and there's probably about 10 really consistently used ones, and the 3 probably most broadly used ones are REAIM, which many of you have heard about, is Russ Glasgow's REACH, efficacy, effectiveness, adoption, implementation, maintenance, the stages of implementation, and the CFR, the Consolidated Framework for Implementation Research. I think all these slides are going to be available to folks, and so just to say, some of the stuff I have is more just as a reference than anything. But just to say that using an organized framework for implementation research allows you to be thoughtful about the types of questions you ask and also what you measure as part of your study approach. How does it, the outcomes that we focus on look like compared to other outcomes? So often, the things that people are most interested in are the health outcomes at an individual level. Those could be, incidence of disease, mortality, morbidity, DALYs, qualities, etc., or client-level outcomes in terms of their satisfaction with services. We've seen a lot of service-level research in terms of looking at allocative or technical efficiency of services, coverage, equity, I know is a big element here, and looking at that as an outcome. Implementation outcomes are separate from that, and so we have acceptability, adoption, appropriateness, cost, feasibility, fidelity, penetration, sustainability. And I'll say the Society for Implementation Research Collaborative has a website where they have all these different indicators and you can join and really look to use validated indicators so they don't make them up as you go. This is one of those sort of like reference slides, but I'll say fidelity is the one that people tend to focus the most on, right? Was something done with fidelity? Was it implemented appropriately? But it's not the only one. And so I would sort of say that often I should say acceptability and fidelity are the two, but it's really to say that there is a broad range of different implementation outcomes that you might want to collect that might tell a more sort of comprehensive story. One of the things that exists, and I think it affects us a lot, is really this tension between internal and external validity. Right, so internal validity are those traditional study designs where you focus a lot on controlling study biases and making sure that you can compare your arms or the randomized design or not. And I think that's really where efficacy work fits. With implementation research, there is this focus on generalizability and doing this in real-world context. And so I'll just say that you have to recognize that you give up some of that internal validity, that they really are at odds with each other, and you have to find the right balance for the question that you're asking. But to develop guidelines, ultimately the WHO or others will want efficacy work, they'll want effectiveness data, and they'll want data to inform like this idea of cost for sustainability and scalability of programs. And so you'll see in the way that, I'm not including it today, but in how different companies or different organizations and different governments judge evidence, you'll see them value all of these. I'll also say that, often when we work with trialists, so in HIV, for those of you, for example, like vaginal microbicide, right? Like there's a lot of work could have been done. So some of you may follow these trials, like the FACT-001 study, like a $250 million study that didn't work at all, right, in terms of the tenofovir vaginal microbicide. Or some of the early work around rectal microbicides and just microbicides in general. The reality is that some inclusion of implementation indicators at an earlier stage of those work probably would have prevented those $200, $300 million phase 2A, phase 2B, and phase 3 studies from moving forward, because they might have recognized that people wouldn't use the product as was developed. And so we can talk about that, but the idea is just like, can we think about better inclusion of some implementation indicators in like phase 2As or phase 1 studies that might give you some insight? And I say that's important because like a drug company, pharma would never move forward with like a product that wouldn't work or that there would be no market for. But I think with HIV, because it's Gates and it's USAID and others moving forward, there's less risk aversion in terms of moving forward with large trials that may or may not be useful. But obviously at an end stage, it's really important because if we don't have 5,000 or 6,000 people enroll in a study that we know probably would have never worked if we really thought about it. So just as an example, I've made sure not all the examples were HIV, although that's where I spend a lot of my time. But so as an example, corticosteroids for preterm delivery, I think many of you will know that we use corticosteroids if somebody is for sure going into labor in preterm, and that's really to avoid respiratory distress among neonates. And so the World Bank moved forward with a large study, 100,000 women across 6 low-middle-income countries, Argentina, Guatemala, India, Kenya, Pakistan, and Zambia. And they used steroids in about 6,000 of the women, and there was actually an increase in mortality of about 12% among the infants in that study. And and ultimately what it came down to is actually most of those children were not preterm, right? That there was challenges about what was the actual gestational age of the babies, and they were actually giving steroids to term babies, which we know can cause immunosuppression and adverse outcomes. So one of the things that this as a case study took, that I think the field and the community learned from that is that none of the 21 studies had actually provided any of the data about the settings in which this work was done. When it was looked at, it was of course that these were done in tertiary coordinary centers where people had 8-week, dating ultrasounds, 18-week anatomical ultrasounds, and they had a really solid understanding of gestational age. And that's very different than just using last menstrual period, for example, as a measure. And so it was just about that context matters in these studies, and I think a number of these real-world examples with terrible outcomes. And so, within implementation research, the conventional paradigm is often like, well, if it works, like USAID or maybe Global Affairs Canada wants to run with it and scale it up. I think the pushback that we're having is like not just does it work or does it not work, but like what are the conditions that you would need to make in order for it to work? Can you meet those conditions in the settings in which you're working? And if you do, then you may very want to think about iteratively scaling it up. So some of you may be familiar with the STARI outcomes. I will say that we got scooped on this process, but we were also looking at developing a series of outcomes that you would have to report whenever you submitted an implementation research study, in the same way that you do for an RCT or a meta-analysis or an observational study. That the Equator Network, many of you may be familiar with, whenever you submit a paper, has to have these different measures in there. And so there is now the STARI outcomes, which are basically implementation outcomes that you should be reporting as part of any study. And I'll just say that there's lots of information in there about describing your study setting, describing any changes that you have to make in order to get that study setting to a place where they could implement your intervention, report the readiness to change, etc. And then the other key thing is really this element about really specifying your intervention. Often people will say, like, we did peer education, and it's really hard to know, like, what of that you actually did. And so there's a lot of information in there about, like, what was the temporality or the dose, etc. of your intervention. So just in the context of HIV, we did a review a couple of years ago where we looked, it says under review, but actually it was published last year, where we looked as a field in HIV, like, how do we do about reporting these different outcomes? So after an intervention is like, is it a doctor, is it a nurse, is it a peer, etc. What is the action? Like, what is it that they're actually supposed to do? The dose, so if it's peer education, is it a 10-minute visit, is it a half-an-hour visit, is it an hour visit? What's the temporality? Do the peers do this on a weekly basis, a monthly basis? The implementation target, and then the behavioral target. And I think just overall, I'll say that, like, this told us we're really good at reporting behavioral targets. We're really good at saying, like, we wanted them to increase condom use or to increase testing. But we tend to be really poor at saying, like, the peer educator, did you give them a one-day training? Do they have a high school education? Are they university educated? Really specifying these elements as part of an intervention to ensure that other people in another part of the world can see, or even in another city, can make an educated decision about, is this an appropriate intervention in my own setting? So then in terms of designs, again, racing. So in terms of designs, I'll say, observational, like, a lot of the designs are actually very consistent with designs that you use in other settings. The only one that's probably specific is this idea of hybrid designs. But I'll say that, we use experimental designs, and those can be, and I'll give some examples of, like, a pragmatic randomized control trial. I'll talk a fair bit about hybrid designs. I'm not going to talk about quasi-experimental designs, but I'll say that this is really a field that is blowing up right now. And there was a really nice annual reviews of public health paper of quasi-experimental designs, including, like, regression discontinuity and natural experiments and how to effectively use those, because in the program space, it's a really good design to use. And then I'll give one example of a modeling study that we've done in collaboration with Sharmista Mishra, who's an investigator here in Toronto. So this is another piece from David Peters' paper, but it really, I think, does a nice job of, like, laying out when you're studying pure efficacy work, and really there's, like, the idea of implementing it may not be as relevant, but then thinking about how you're moving through this stage where it actually is all about implementation, right? And so for each intervention that we have, whether it be PrEP or whether it be treatment or whether it be technical, like technological interventions or health, etc., you have to make a call about where you are in this space and how much you're going to value collecting implementation indicators. And that's only because you only have a certain amount of data you can collect, right? If it's from a participant, you can only have that participant in front of you for so long. If it's from a program, you can only ask them to do so much, or in a clinic or whatnot. So you really have to prioritize, like, what is it that you need in order to answer your primary question. So, hybrid designs broadly are grouped. So these are experimental designs that are broadly grouped into hybrid type 1, hybrid type 2, and type 3. And our little plug within implementation is that, like, there should be no RCT that is not at least a type 1 hybrid design. And all that really means is that you've included some implementation indicators along with all your effectiveness outcomes and all your work around effectiveness, that you might include just a speckle of implementation indicators in there and really prioritize those. Type 2 is really where you're somewhere in between. You have an equal amount of weight for both effectiveness and this idea of testing implementation approaches. And then type 3 designs, which we're seeing in the field, like, we focus more on NIH funding, but nowadays you'll see more of these type 3 designs being funded, and that is, like, we're not testing PrEP anymore, but we're testing differential delivery strategies for PrEP, for example. So it's like we're testing the facility-based versus the network-based, etc. So it is purely in the space of implementation. So pragmatic trials have been around for a long time, but the idea here is that you're testing a new intervention while maintaining and really maximizing external validity. And so this might be, and I'll give an example of the PrEP study, the PrEP RCT study from the UK. But you'll have both sort of directly and indirectly collected indicators here, and obviously you'll collect some about, as I mentioned, health outcomes and service outcomes, implementation outcomes, and then the idea of collecting resources, because often pragmatic trials are being done to increase the cost effectiveness of the delivery of a particular intervention. When we think of resources, it's important to not just think of money, right, but to also think of institutional or other resources, and there's a series of different analyses. And then, like I said, increasingly, we're seeing this being done in the modeling space, and so working with really great modelers that are not just modeling the effectiveness of outcomes, but actually modeling differential implementation approaches. So how many folks are familiar with what PROUD was in the UK? So not so many. But so this was, right, so this was Sheena McCormick's study that was done in the UK, and it's a great example of a beautifully done pragmatic trial. So this was in the context of infectious disease clinics, primary care clinics in London, and basically, they had their standard set of services that they offer in terms of testing and STI treatment. And what they said was, we're going to randomize people to either get PrEP right away or get the standard of care in terms of STI management for 9 months, and then they're going to get PrEP. So you can also think of it as a pragmatic trial or a single step wedge design. They didn't power this. They did it as a really nice way. They didn't power it based on HIV incidence. They powered it basically how long it would take them to accrue 500 folks, and then retention at 12 and 24 months. And then they had secondary outcomes, including incidence and a series of clinical outcomes. And so again, this is just, these are folks that are arriving in the same way that they would in Toronto for an STI. They're symptomatic, or they're asymptomatic but concerned that they had a high-risk exposure, and then they basically get randomized at that time to either getting PrEP or not getting PrEP. And this was a study design that was supported in the context of the existing clinical systems. It didn't require a lot of time to get up and running because it wasn't being collected in some beautiful setting. It's just being collected in the context of their existing clinics. But this is a fundamental study in PrEP, right? The 86% reduction in incidence that was shown in this study. So it's just to say that if you compare this to the IPREC study, which was the US version of it, or actually the international version, but it was the US. There, it was like all these clinics were set up kind of de novo, people were recruited in, and that study cost ungodly amounts of money as compared to doing this in the context of existing systems. So set wedge design. Set wedge designs are particularly important in the context of existing, where you have a lot of government-supported programs. And I'll just say, so, set wedge designs are basically where you have different time periods and different clusters. And the idea here is that when you're implementing a program, just naturally, that you don't scale up a program from nothing to full scale all at once. So the idea of a step wedge design is to be a little bit more deliberate about that, right? Is to, to split up basically the places where you're going to implement into different steps and have different clusters. And the only thing that you're going to do is basically have these different time periods, and we'll talk a little bit more about what time periods are. But you'll do one full time period where you'll collect data across all of these clusters, and then you'll slowly scale up. First in 1, 2, 3, 4, 5. A lot of flexibility in these, but I'll say that these are particularly nice design because you don't have to tell somebody you're not going to get it. The reality, we're implementing this intervention, but you've been randomized to a control type model. The reality is that they're going to get this intervention in the same way, like I just gave an example of PROUD. Folks got the intervention and decided. So I'll say that we've seen a lot of increase in, and there's been a couple special issues about step wedge designs because they got to be very popular for a while, and now I think there's a little bit of a retreat. But I'll say briefly, in terms of those, like I said, it's a really nice design because it allows everybody to get the intervention. There's really mixed ethics because people will say, well, we're not randomizing anybody to not get the intervention. But the challenge is that, if you already know an intervention works, right, why are you even randomizing people at all? Why are you just trying to scale it as much as you can? So I think this message of, not, we're not randomizing anybody to not getting it, if you don't have equal voice for your question, there's sort of a clear ethical concern there anyway. And then the other dynamic, and I think is important, is for those of you guys who are involved in programs, you'll also know that your program gets better over time. right? And so that the folks getting exposure to the intervention here are probably getting a better and more efficient program than the folks who got it in the earlier stages. And so there's a clear sort of analytic concern there. And then I'll also say that the intervention effect has to be able to be measured within a single step. So if you're looking for viral load suppression, you have to be able to achieve that within a single step before you move to your next step. So when you look at some of these designs, they can be 6 or 7 years long because of that idea of like needing to achieve the effect within a step. So it's often hard to do these within the context of like an R01, like an NIH-funded study, because the max we have are 5 years. This is a quick example of what a step wedge design looks like. So this is a pragmatic step wedge design that was done in the UK. And basically, this is the idea that when folks are admitted into hospital, especially elderly folks, we don't want them to lose weight, right? That is one of the things that can happen to folks, and that is a direct measure, direct predictor of mortality and morbidity for folks, and also readmission. And so this was a step wedge design where basically the primary outcome was patient body weight, but there was a whole series of secondary outcomes. The measurement time was 2 months. So the idea was that they would measure basically patient weight within 2 months, and then the step would be 3 months. And they would have 5 steps across these 25 different clinics, split across 4 different clusters. So then adaptive design. And again, each of the references are available for you just to sort of read them. Adaptive designs and adaptive interventions, I think, are right now probably the #1 design if there was sort of, hate to put a value proposition, but there's a real interest in this idea of adaptive designs because we recognize that not everybody needs or deserves or wants the same intervention. In fact, the sort of language of differentiated care is often becoming, sort of the norm. And these designs allow you to test that in a formal way and balance some issues about internal and external validity. So the trial design is often called a SMART design, or a sequential multi-sided randomized trial. And it's sort of like, you guys remember Encyclopedia Brown, where you choose your own ending, right? So you get to a page and then you're like, I choose this or I choose that, and you kind of keep working your way through. The idea is here that you use the outcome data to then inform randomization. So I'll give an example of a study that we have underway again with Sharmistha Mishra. So this is a study being done in South Africa that's funded as an R01. It's a nursing-led intervention for sex workers living with HIV who are not virally suppressed in Durban, South Africa. So the idea here is that, if folks were able to be, if their treatment needs were being met by the services being provided already, then they're not eligible for our study. So then they're doing great, and we're only focused on those folks who we've seen enrolled into the program for at least 6 months and who remain not virally suppressed. And at that point, they'll get randomized to either a decentralized treatment program, or where we deliver treatment to them, or an individualized case management program. And you can see that after 6 months of getting this intervention, if somebody's virally suppressed, then they will get either randomized to continuing on the decentralized treatment program, or actually just going back to the standard of care. So it's testing that idea of like, did that person just need a little push in order to have their treatment needs being met, and then their standard of care can better address them? If they're a non-responder after 6 months, so we've implemented this program here, we've delivered treatment to basically their community, then they're going to get randomized to getting both interventions. So the decentralized treatment in addition to individualized case management. And so the idea is just that we made a randomization decision based on what their outcome was, based on their previous exposure, and sort of follow the same thing down in individualized case management. And then I'll just talk about Sharmista's work because it's really important. Increasingly, as I noted, we're using modeling to look at different implementation strategies. And so here you can see, we're not testing the effectiveness of treatment, right? We know treatment works, right? We're talking about our differential delivery strategies and implementation strategies for treatment. And so Sharmistha is modeling out the incremental cost and incremental impact of these differential delivery strategies for implementation, and asking this question about who and under what conditions is most going to benefit, because that's ultimately what we're trying to ask. And so, the idea is in her simulation, you can have these different you can have your different interventions and different implementation approaches, and you can move through and have a relative hazard of either not being virally suppressed or being virally suppressed, or dying or not dying, based on your exposure to these different interventions. And the outcomes are not purely infections averted, but there are elements around durability, and then ultimately proportion of viral suppressants. And you can then take these data and then model them out to the broader community. So this is focused on sex work, but what does that mean in terms of the overall epidemic, for example, in Europe or across South Africa or across Southern Africa? I think just in the sake of time, this is just a little bit more of the mechanics of what it looks like. But the idea being, again, that people are moving their way through the microstimulation, not based on do they get PrEP or do they not get PrEP or do they get treatment or not get treatment, but just their exposure to different implementation approaches. And so you can look at this in terms of like the same single intensity, like they just get individualized case management, or you can look at graduated intensity where they get exposure to both interventions and makes the case. And she also looks at this, and I'll just say about de-implementation, about if we take somebody who is getting decentralized treatment programs and then stop that intervention, what happens as a result of that, and do they revert to being virus suppressed, or should they virus suppressed? Current sample size calculations for these studies are really complicated. I'll say that often people will power, so for the NIH, and I'm sure it's similar to CAHR, like, you can't submit a grant without a power sample size calculation. And so, and even that is also true in the space of implementation. But it's more complicated, especially within hybrid designs, because you have these two primary elements you're looking at, both effectiveness and implementation measures. And so you kind of have to make a decision about, like, what is it that you're going to have your primary outcome powered on? So what is the one question that you're absolutely going to be able, or you think you're going to be able to answer, and then make decisions about the other elements. And I'll just say that increasingly we're using modeling approaches in these microsimulations to help guide how many people we even need in these studies to then and use that as a power sample size, because it's just too complicated to do it just based on a traditional like differential, outcome. The implementation is also, I mentioned it, a little bit as one of the designs we're looking at. The implementation is a really important piece, and I'm sure in the Ontario context, it's also important. Like, folks are implementing all kinds of different interventions, and things just get added to the package. And, one of the things I think folks are looking at is, like, what can you take away from that package and actually still achieve the same outcome in terms of whatever you choose as your primary outcome. And so de-implementation studies, like at the last D&I conference, which is an annual NIH-supported implementation conference, there was like 6 or 7 of them, but I think increasingly we're going to start seeing these designs, which are similar. You can have cluster randomized control trials, except the only thing is you're taking away something. And you're just basically looking at like non-inferiority design. So just as a summary, I think the concept of implementation research is that we're intended to seek generalizable knowledge. We really want to close this gap between evidence and practice. I think as Janet mentioned, this idea of like always being, self-reflective of this tension that exists between internal and external validity. And so that as you think about what is or is not effective, that you're cognizant of like the clear limitations that you have to kind of accept in order to answer your question. And I think there's a really rapid evolution of both adaptive designs and these microsimulations that I think are really paving a way forward to being able to answer larger implementation questions. I'll stop there.
Okay. So thank you.